Okay, hi, my name is Amy Kontorovich, and I'm a physician at Mount Sinai. I'm an assistant professor of medicine and cardiology and the medical director of the Adult Cardiovascular Genetics Clinic. And today I'll be speaking to you about a few projects that kind of tie in with an emerging phenomenon that we're seeing in COVID-19, which involves patients with long-term chronic debilitating symptoms. So you've probably seen this picture countless times. It's all over the news. It's all over our media feeds, social media. But COVID-19 has been the global pandemic of 2019 to 2020. And we know that it's caused by a particular virus, and it's affected about 7 million people in the US thus far. And most of the early attention in the media and in scientific reports has been on the acute phase of the illness, which primarily is manifested as a respiratory illness, but has been associated with numerous systemic symptoms. Many reports have emerged of patients having gastrointestinal symptoms, even dermatologic symptoms. So we know that the virus doesn't only affect the respiratory system. It's fatal in many cases, and especially in the early phase of the pandemic, the fatality rate was quite high. And there are defined risk factors that have emerged, including older age, male, obesity, patients with pre-existing conditions like heart disease, cancer, chronic kidney disease, lung disease, etc. And in rare cases, we know about certain complications of the acute illness that patients can have, for example, myocarditis or acute inflammation of the heart, and children that have been identified as having a severe inflammatory syndrome. But those are rare complications, and again, focusing on the acute phase of the illness. What began emerging towards the middle of April and has intensified over the ensuing months is a phenomenon of chronic COVID-19 illness. And there have been several high-profile reports on this condition, but it's clear that in some cases, patients with COVID-19 will have potentially a more severe, but often a mild acute illness when they're infected with COVID-19, and then may have lingering symptoms that can last for weeks and months. In some cases, we have patients who have had symptoms for 6 months. So there are a community of individuals, patients who have collected and gathered across social media virtually and collaborate on this from the patient perspective through various Facebook and Slack groups. So they're calling themselves long haulers, and this is a term that you may have heard already, but we're still learning a lot about this long haul phenomenon. So several of the groups have begun doing their own kind of patient-led research and sending out surveys and trying to collate this data and put together some kind of scientific summary of what this long haul syndrome really is. And here at Mount Sinai, we've also taken a systematic approach to try to learn about what this long haul syndrome is, understand what the associations are, understand what the symptomatology is, and try to help patients who are still dealing with this unfortunate condition. And so through this partnership with the Precision Recovery Program at Mount Sinai and this team of multidisciplinary specialists, which is led by David Putrino, we've developed a program to try to learn more and to help patients. And the program at this point consists of an application called MyCap, where a patient can track their symptoms, and we can get that data back and understand what the dynamics and the range of symptoms are, as well as interfacing with providers through Zoom and also in person to learn more about the symptomatology and the clinical features that link to the symptoms. And that is integrated also with a survey that was that was administered to patients who were willing to participate. So the process for patients who participate in this post-COVID precision recovery program is that they would be identified by a provider, either in the clinic or the emergency room, and felt not to have sufficient symptoms to merit admission to the hospital, but that they would be recommended for remote patient monitoring, and then that would sort of activate their enrollment. And once they were enrolled, they would complete this daily app based on their symptoms, and then they would have regular check-ins with providers. And if there's any concerning symptoms in one of those check-ins that would be more concerning than just the burden of symptoms, but something that might indicate a need for hospitalization or further workup, the physician or clinician extender would recommend a visit to the ER. And then otherwise, the patients would have a weekly check-in through Zoom or the phone. So I'm going to put a pause on what we're doing here at Mount Sinai and transition to what's been reported already about post-COVID illness, post-acute COVID illness. So there is a group in Italy that published in July the first report about chronic COVID-19 symptoms. So they studied 143 patients that were all hospitalized for acute COVID-19, and they all had severe enough illness to be hospitalized. So that's a cardinal feature of this study, is that all the patients had what we would say would be moderate to severe COVID illness. Most of these patients still had residual symptoms on average 36 days after their hospital discharge. And there was overlap between the symptoms that were present during their acute illness and the symptoms that were residual and lingering in the post-COVID phase. Notably, the main symptoms in the post-COVID phase were fatigue and dyspnea, but also interestingly, joint pain, chest pain. And the symptoms that also were highly prevalent during acute, some of them were not as highly prevalent in the chronic phase. So cough had largely resolved, myalgia, lack of appetite, headache, those had largely resolved. So many of the people who have been looking at this since the spring have been postulating about what this set of symptoms could be. And as of that July report from the Italian group, there was no real name for this. There wasn't a specific diagnosis that was being attributed to patients who had lingering COVID symptoms. But there were a lot of postulates about what the syndrome could be. Now, it may be something brand new that's never been defined, but it's also plausible that the types of post-viral complications that have accompanied other viral illnesses in the past may be responsible for the symptomatology here. And some of them are highlighted on these screen grabs of different publications that have emerged in recent months. So myasthenia gravis, Guillain-Barré, that those have been proposed as possible entities. But in most of the cases that have been reported for these chronic patients, a diagnostic entity has not been defined. And myasthenia gravis and Guillain-Barré would be examples of diagnostic entities that would be defined. There are a category of symptoms that fall under the umbrella of dysautonomia. And that is not truly a diagnosis, but a category of sub-diagnoses. And that is the leading hypothesis that our group is working on, that the symptomatology in post-acute chronic illness is due to some form of dysautonomia. So dysautonomia, like I said, is an umbrella term. It encompasses multiple diagnoses, including something called POTS. So POTS is an acronym for postural orthostatic tachycardia syndrome, and it's the most common form of dysautonomia and one that physicians and clinical providers are most familiar with. But there are multiple other forms. And many patients will have dysautonomic symptoms and characteristics where they don't meet specific criteria for any of the diagnoses listed here. So in those cases, we just label it dysautonomia. And patients who have dysautonomia symptoms, and I'm going to talk more about what those symptoms are, often report that they come in cycles, and they usually have a number of symptoms, not just one, but many symptoms. They can have relapses that come with the seasons, often triggered in the warmer months, in the hotter months. And what makes this a tricky set of diagnoses to land on is that those symptoms and their features can overlap with other disorders. So many times the symptoms can overlap with anxiety, or there has been kind of a hot debate, especially with regard to post-COVID, about these symptoms being due to something called chronic fatigue syndrome, myalgic encephalitis. But that is sort of a debated entity. And first and foremost, and I should really have put this as the first bullet point, is that dysautonomia comes with a lot of skepticism, many times from providers, because it's really challenging to make an objective diagnosis. So we're dealing with something that's a constellation of symptoms, but doesn't often have any objective measurable impairment that we can record. And so it's challenging for providers to accept that this it's a true entity, and so patients are often doubted in what they're experiencing. It can be really frustrating for patients and also for their providers. So talking a little bit about what dysautonomia really means. So the autonomic nervous system has the sympathetic and the parasympathetic component, which should be in balance and should be activated in different ways depending on circumstances. So everyone knows about like the fight or flight response from our primal caveman days. We saw a tiger in the forest, in the jungle, and we run. And that's the fight or flight response. Is an activation of the sympathetic nervous system, and you get this adrenaline surge, this epinephrine. That's a sympathetic surge, and we have the capacity to operate in that fight or flight mode because of our sympathetic system. But if we always operated in that mode, we would feel pretty awful. And so our parasympathetic system balances it out. It evens the score. It levels out the hormones so that we are capable of doing other things besides running from tigers. We can digest our food. We can have saliva to help with our eating. We can use the restroom. We can void. All of these things are aided by parasympathetic responses. So it's a delicate balance between these two systems, which I very greatly oversimplified. But the dysautonomic phenomenon is caused by some form of imbalance between these two parts. That is part of what causes dysautonomia. And this is nicely summarized on this little infographic, but there are multiple manifestations of this imbalance. So first, just starting from the numbering that's in the infographic, is that patients can have pooling of blood in their lower extremities. So that means that when they change position, they do a poorer job of adjusting their blood pressure, and they feel kind of dizzy, or they might be even faint if they change position quickly, like getting out of bed quickly or standing up quickly. This can cause a decrease in cardiac preload. It can cause poorer perfusion of the brain, not to the extent that it can lead to ischemic changes or injury, but the body perceives those small, subtle changes in perfusion, and it causes dizziness and sometimes visual changes, tunnel vision in patients who have some of the orthostatic involvement. It can also lead to a response from the baroreceptors to activate the sympathetic system and cause more adrenaline surges, because there's a perception of the hypoperfusion, and that can cause the heart to race and try to increase the cardiac output and cause a sensation of palpitations. And the reaction to being exposed to all of these features chronically can cause the symptoms that are listed in the box to the right. So that is feeling like you're going to faint, near syncope, truly fainting, syncope. Fatigue is a major component of this. Headaches, brain fog. By brain fog, we mean like feel like you're walking through molasses. Patients tell us that they can't find their words. They're talking to someone and they're just completely out of it. They can't focus, they can't concentrate. And just thinking back to what I mentioned about overlap with other symptoms, another major area of overlap is with attention disorders, ADHD, because of this inability to focus and the brain fog because of the hypoperfusion. Anxiety and depression is part of this. GI symptoms are a big part of dysautonomia because of gut hypoperfusion, nausea, early satiety, motility problems sometimes. And then the inability to exercise. And I'm going to show you a figure with a chicken and an egg. We don't know whether this is inability to exercise is because of all of the fatigue from the all the processes that are listed here, or if it's the exercise issue is actually causative. I'll talk more about that in a moment. And there are many, many associations with dysautonomia, and you can see this citation on the bottom. It comes from a paper from before COVID, and you can see that post-viral autoimmune is part of one of the well-established causes of dysautonomia. Okay. So we have a paper under review at the moment where we've done the first kind of collection of data from the Precision Recovery Program on the post-acute COVID-19 syndrome patients. So the first collection comes from 84 individuals who were previously healthy and all experienced a mild acute COVID-19 illness. So in contrast to the Italian study that I showed you a few slides back, where everyone who was reported with chronic symptoms had a moderate to severe acute illness, these are folks who primarily were not hospitalized. So they had pretty mild early symptoms, but those symptoms persisted, and with an average of 151 days out, they still had persistent symptoms. So these individuals were administered a red cap survey to address the symptomatology and quality of life score, as well as a breathlessness score and a fatigue score. So the results are summarized here. So 69% of the respondents were female, and they were relatively young. So the mean age was 44. They reported 35 symptoms, including persistence of the symptoms that they had during their acute illness, and 99% reported they were not recovered from COVID-19. Most of them, a far majority, reported disability that they attributed to feeling breathless, feeling short of breath. And the majority also reported fatigue, and on the fatigue scale that we used, it was a fatigue level of greater than 50 out of 100, and 82% reported a worsened quality of life after COVID. The symptoms that were most prevalent in the chronic phase were fatigue, loss of concentration and memory, weakness, headache, and dizziness. And those do overlap with some of the symptoms that were reported in the Italian paper, but they also greatly overlap with the symptoms that we know to be related to dysautonomia. Now, again, major caveat is that these symptoms can occur in a lot of different conditions, but when we see the collection of symptoms together in one patient, many of these symptoms together in one patient, it's highly suspicious for dysautonomia. So there is no one test that can objectively diagnose dysautonomia, and that's what makes this a very tricky label to slap on a patient who has these symptoms. There are numerous tests that are available, but they each interrogate for a specific form of dysautonomia. So for example, you're seeing a picture of a tilt table test. A tilt table test is just what it looks like here. A patient is laying on the table, which is tilted, and the patient is left to stay in that position, and the heart rate and blood pressure responses are measured over time. And if a patient has POTS, they will have a heart rate response of greater than 30 beats per minute sustained in that upright position. It also can provoke their symptoms and make them feel really uncomfortable. And there are other tests that can look at the different forms, but we don't just have one global test that can say you have dysautonomia or you don't have dysautonomia. It's really a clinical diagnosis based on symptoms. So I'm just going to segue briefly into what we know about the cardiac features of POTS specifically. So this is work from Benjamin Levine's group from about 10 years ago, where they looked at the cardiac profile of POTS patients compared to healthy controls using cardiac MRI. And they were the first to kind of definitively show that POTS patients had, on average, smaller hearts with lower blood volume and smaller left ventricular mass compared to the healthy controls. And because of this, they labeled POTS the Grinch syndrome from the Dr. Seuss character, that, you know, because he had the heart that was 2 sizes too small. So it's kind of an unfortunate moniker because these patients are really miserable, and I think it's not fair to further mock them with that name, but that's just to kind of drive the point home that they saw this association. And the interesting aspect of this is that this group was also studying cardiac morphology of competitive athletes when they stopped exercising. So we know that competitive athletes and endurance athletes can have a cardiac response where their hearts enlarge from exercise, where the heart walls can get thicker and the chamber size of the heart can also get bigger. And when they stop exercising, that often goes down, both the thickening and the chamber enlargement goes back down. But in many cases, it can kind of swing too far and the hearts can become too small. And that's something we call cardiac deconditioning. And the group that looked at these POTS patients sort of felt like the morphology was similar in POTS, and it looked like cardiac deconditioning on MRI. So this is just another way of visualizing the data showing that the POTS patients had lower blood volumes and smaller left ventricular mass compared to controls. So this leads to that questioning of the question of cardiac deconditioning. And it's still something that's debated whether or not deconditioning is a cause or an effect in POTS. But what the Levine group did is they developed a protocol for patients to exercise, and they call this an aerobic reconditioning program. And they found that in those who were able to complete it, 71% no longer had POTS. And so there is no drug or medication that can reverse POTS. This is really the only evidence-based treatment for reversing or curing POTS, and it also was associated with significant improvement in quality of life. And what they found is that the exercise protocol led to an improvement in the cardiac morphology that was more closely approximating that of the healthy controls. Okay, and this is showing some of the quality of life scores getting better with the exercise and some of the hemodynamic parameters improving as well. So here at Mount Sinai, we've looked at this question in another cohort more broadly, and we see a lot of patients who have connective tissue disorders associated with hypermobility, and that's one of the conditions that's strongly associated with dysautonomia. So we recently completed a retrospective cohort study in 140 patients who we had seen for one of the joint hypermobility disorders, and looked at the incidence and symptomatology of dysautonomia, and also exercise features and echocardiographic features. And so I'm just going to show this briefly. I can go into more detail on this on the second call, but just to say that dysautonomia was highly prevalent across all of the different forms of hypermobility disorders in this study. And overall, we found that 70% of the hypermobile patients had some form of dysautonomia, and they were majority female, so we had 93% female. This is also something that's kind of well known about dysautonomia, that it is more common in women. The symptoms of dysautonomic patients in our cohort also were very similar to what was seen in the post-acute COVID study that we did here at Mount Sinai through Precision Recovery, as well as to the Italian study. Exercise intolerance was #1, but you can see so many of these other symptoms are on the lists from those other studies: fatigue, dizziness, poor concentration. These were really common, and most patients had 5 or more symptoms. So this spectrum and degree of symptomatology is part of what defines dysautonomia. And we also found that exercise was associated with dysautonomia. So patients who developed dysautonomia were more likely to go decline in their exercise category, and sedentary lifestyle was very common in the dysautonomic patients. And finally, we looked at the cardiac anatomy of the dysautonomia patients, and we found that the trend was compatible with what had been reported by the Levine group, that dysautonomic patients among those with connective tissue disorders tended to have smaller cardiac dimensions compared to both controls and those without dysautonomia. So we didn't have a formal control group as part of our study. We just initially compared those with and without dysautonomia, but we used healthy reference data to draw the comparison. Not a perfect comparison, but it was trending toward smaller cardiac size in the dysautonomic patients in our cohort compared to reference normal values. So the summary of what we think is going on in patients with joint hypermobility disorders and connective tissue disorders is that there's some flare of their connective tissue problem that can trigger the dysautonomia and lead to this burden of symptoms, which we're not sure whether that leads to the unfavorable cardiac geometry through a deconditioning mechanism, or that they're sort of predisposed to the dysautonomia because they have an unfavorable cardiac geometry from the get-go. But overall, this process causes them to have exercise intolerance first and foremost, and so they end up more likely to become sedentary and avoid exercise. And what we've done is develop an exercise protocol through our cardiac rehab program to approximate what the Levine group had done in their study of POTS patients and apply this more generally to those with dysautonomia. And so this is just highlighting an example of one patient who had participated in the program and actually completed it. And the program involves kind of stepwise, incremental aerobic exercise to try to achieve a target of 30 minutes of sustained moderate intensity exercise. So on the first session of this representative patient, this individual was able to perform 7.3 METs, which is metabolic equivalence, and his heart rate went to 127 beats per minute, and the blood pressure rose to 172/70. And keep in mind, his resting heart rate was not abnormally high, as we can see with patients who have dysautonomia, but it went to a pretty high rate at a relatively low wattage, a relatively low effort level. On the right is his summary of exercise at the completion of the program. So he did this gradual, stepwise, incremental exercise program, as you can see, over 5 months. And by the end, he was able to achieve a few metrics of success. So first of all, his peak heart rate at a much higher wattage than at a higher MET level, which was 8.1, was only 116 beats per minute. So he had a normal kind of chronotropic response to exercise, whereas he had an exaggerated chronotropic response at baseline. The blood pressure also rose appropriately, but did not become hypertensive with exercise. And he had an appropriately normal blood pressure at the start and the end. He was somewhat low at the start, but his resting heart rate was also lower. So this was like an example of how the aerobic reconditioning was able to improve his hemodynamics. And this individual also had significant improvement in dysautonomic symptoms by the end of this therapy. So back to COVID, one of the theories that we're working on now is that the same kind of infographic that we've summarized our experience with patients who have connective tissue disorders causing dysautonomia, we think that may be what's at play in post-acute COVID syndrome. So we think that healthy, active people, many of them young, and many of them who were well enough to not succumb to moderate, severe COVID requiring hospitalization or death, were susceptible or somehow developed something either dysautonomia or like dysautonomia, but many of the symptoms are overlapping with what we've seen in the past with other dysautonomia cohorts. We don't yet know if there is some correlation with unfavorable cardiac geometry in this group. We don't know if they will show a similar pattern of having smaller cardiac dimensions. We don't yet know the connection with exercise. We don't know if these are individuals who were highly active before and then were kind of transiently delayed or halted in their exercise because of the infection. We do know that dysautonomia can be provoked under those circumstances. In a person who was doing a lot of exercise and then for some reason stopped or paused, it can unmask the dysautonomia symptoms. So that's another potential explanation. We don't yet know if these are patients who are going to be avoiding exercise, but we do know that exercise is a trigger of their symptoms. So there's a lot more question marks than check marks here. We really have a lot of areas to investigate. So I'm just summarizing on this last slide the questions that for me are the most pertinent. And I guess the first bullet point is nice if we could resolve this question, but answering this particular question I think is less important than how do we actually understand what's going on and help patients who are suffering in this way. I mean, if we knew that post-acute COVID-19 syndrome was dysautonomia, and we do have experience dealing with dysautonomia, it would help map out a treatment plan for these patients. At the moment, I am presumptively treating my post-COVID patients in this way and affording the recommendations that I would do for any patient with dysautonomia. And so the N is small, it's not a scientific study, this is in the clinical setting, and I'm seeing that patients are getting better, but we really need to study it in a big population. It is a big population. There are more than 50,000 self-declared post-acute COVID patients out there right now. The mechanism, we don't know. We know that something like dysautonomia can be triggered by immune responses, exaggerated immune responses, like I mentioned earlier, by post-viral. There's a lot of buzz now around the effects of COVID on the heart. There have been a couple of high-profile studies that showed that there's residual inflammation in the heart based on MRI features in patients who had COVID, and this is something that came up in understanding how to manage college athletes with COVID. And we don't yet know if there's a deconditioning aspect to this as well. We don't know who's at risk for developing post-acute COVID. Males seem to be affected. Females, it doesn't seem to have a sex predilection that we know of yet, but we just don't know. Age and underlying illnesses, we just don't know. What I think would be really helpful is if we had an objective tool to measure post-acute syndrome, to kind of define it, not to measure, to define it. A test that we could do, whether it was something akin to a tilt table test or some type of blood test, but we just don't know what that test should be. We don't yet know what the cardiac features are in patients who have this post-acute phase of the illness. And we don't know yet how to correlate their syndrome with their physical activity levels, either before they became sick or in the midst of their post-COVID syndrome. And finally, I think once we have better insight into all of the above, it would inform what the interventions and therapies should be. Because right now we're really just kind of trying whatever we think will work and not harm patients, but we're not being led by any data or evidence.